morning. Welcome to Bone Academy. Today's lecture is on bone forming agent. My name is Edward Czerwiński. I am Professor Emeritus of Jagiellonian University and Senior Medical Director of FutureMeds. Bone forming medications I wish to discuss is Teriparatide, Abaloparatide, Romosozumab, and surely we'll close with discussion. We started treatment with antiresorptive medication, and there were bisphosphonates since Alendronate and Alendronate 40 years. And the previous lecture, I discussed the Denosumab as antibody to rank ligand. And now we have a new medication. One of them is based on the PTH derivates. PTH, the hormone which takes care about the calcium level in blood, and it does everything to keep the level of calcium within good range. And if we have the hyperparathyroidism, we have osteoporosis and softening of the bone. But derivatives of PTH acts differently. I will talk in a minute. And him is the conductor of the orchestron of bone remodeling, osteocyte. And where in the absence of loading, osteocytes produce sclerostin. Romosozumab is the humanized sclerostin monoclonal antibody, which stops the sclerostin, so osteoblast is released and produce the bone like crazy. We used to be taught that remodeling is the process of changing bone quality over lifespan, and in osteoporosis, and it starts with the resorption due by osteoclast action. And in osteoporosis, we have advantage of bone resorption against bone formation. So we have osteoporosis. There is quite different possibility of taking care of bone quality is the modeling. So there is no need for primary resorption. It's just stimulation of osteoblast, which produce a new bone. And in this family, we have the Teriparatide, Abaloparatide, Romosozumab. So for increased resorption, we have antiresorptive medication we talked about in the previous lecture. I mean, bisphosphonates and Denosumab. And the modeling, we use just the bone forming agent, and they are much more efficient and quicker. Here is the comparison of remodeling and modeling. So remodeling is the one surface, modeling is the various surfaces. Remodeling is cyclical, it is continuous, and it is very slow, and it is very fast. So definitely better. So the first was Teriparatide, which was the part of the chains amino acid of parathormone. And what turns out that if we have hyperparathyroidism, so we have bone resorption, but if you have non-continuous, just periodical injection every day, Teriparatide on the first stage stimulates bone formation and then bone resorption. We have already 23 years experience. Then we have another derived from the parad hormone, Abaloparatide, also recombinant of the amino acid. Both needs daily injection. And just the newest one, Romosozumab, is the anti-sclerostin as given monthly. We have it on the market already 6 years. Now here is the comparison. How is the difference between bone forming and bone resorption, antiresorptive, and just clearing the nomenclature because we have the mismatch about the anabolic medication and bone forming medication. Anabolic means a hormone reaction, and it is right for Teriparatide and Abaloparatide. But Romosozumab is not anabolic, it's a bone forming. And what they did in US, they just created a new word, bone anabolic. So I don't like it, but you will find it in the literature recently. So coming back to the slide, so we have a Alendronate in red and Teriparatide in blue. And here is the incidence of fracture, and here are the lengths. And you see that after 12 months, the incidence in the Alendronate was twice higher than compared to Alendronate. And this was the vertebral fracture, and quite similar is to non-vertebral fracture, the red incidence of fracture in Alendronate group, and in blue incidence of fracture, Teriparatide. And here is the meta-analysis, and just remind somebody who doesn't know that this diamonds mean the so-called summing above office, and if the diamond touches the one, that means there is no difference. The more to the left, the difference is bigger. So it is not only once, but 50%, really. So you see that this very statistically significant teriparatide reduction of the hip fracture. In Denosumab, the worries is after discontinuation, we have drop of BMD and increased fracture risk that comes to the beginning. And here the teriparatide after discontinuation does not increase fracture risk. Here it is teriparatide 18 months, because you can do it after 18 months and then stopped. And you see any kind of fracture, recent fracture, previous fracture, and total. This is the total study. No difference at all. That is a great advantage. And if we have compared abaloparatide, teriparatide, and placebo, and the incidence of fracture after 18 months, so here it is the abaloparatide incidence, the lowest. Here is the teriparatide, the blue, and placebo, of course, brown, is still high. Here we have a clinical fracture. Here we have a non-vertebral fracture, major osteoporotic fracture, and risk it should be radius fracture. Right. So, but there is this fracture of the distal radius due to falls only. So this is why no medication can act, and there are younger women too. This was about the parad hormone derivatives, and now we switch to Romosozumab, and we skip that. And Romosozumab, as I told you, is the antibody against sclerostin, and it turns out that stopping sclerostin stimulates bone formation, increases number and activity of osteoblast, and reduce resorption inhibit secretion of ganglions. So that means have wonderful dual action. I confess I like this medication. I was in this trial as well, all of them too. As it was the first was the frame, and it was a huge study for 7,000 women. And first year you have placebo, and one group was given Denosumab 202 milligrams, and there was Denosumab, means either placebo or Romosozumab were given Denosumab for 2 years, until 2 years, and there was extension until 3 years. All of them were given vitamin D and calcium. The inclusion criteria was -2 T-score in total hip or femoral neck, and the primary objective was impact on the vertebral fracture after 1 and 2 years. As a measurement were the bone markers, BMD, and X-ray morphometry. So here we see the increase of bone forming action, however, it's dropped afterwards. And here are CTC, or the reduction of bone resorption markers. And here are the results of the fractures. And placebo is in brown, and red is Romosozumab. So we have against placebo 63%. Here it is the clinical and non-vertebral and hip fracture, 41% reduction in a group treated with Romosozumab. In this study, I just mentioned that the cardiovascular incidence were the same in both placebo and treated. And the company audited themselves much more further, and they were head-to-head study, fracture study, what is a unique study and the biggest nowadays. So there was no placebo. There was a control group treated with Alendronate, and as an observation, a treated group with Romo 1 year, and afterwards all of patients were put on Alendronate. This was 4,000 patients, and they had less than -2, and vertebral fracture or femoral neck fracture. Does mean there was a group of very, very high risk of fracture, therefore they couldn't be placebo. Everybody were given either Romosozumab in the treatment group and Alendronate in the observed group, vitamin D, of course, and calcium. The primary objective was the incidence of vertebral fracture as proven on the X-ray morphometry. And here we have, and there was also a bone biopsy. And here you see the bone forming action, and bone is osteoblast and osteoid. You see there is increase of 14% in Romosozumab and 7% in placebo. I mean, and there was also a surface and in placebo. So there are from the study from the first study. And the same we have in the trabecular thickness. I've had the placebo compare the thickness of trabecula much more higher and trabecular very much more higher. So this is really bone forming agent, as you see beautifully on this micro radiogram of placebo and in Romo. Having the bone density and the CT scan, we know the features of every pixel, so we can, using a method, calculate the resistance to strength, and you see how the strength of the femoral nail is under alendronate treatment and many times stronger in Romosozumab treatment. The most important is the fracture risk, and just I remind you, there is no placebo. There is treatment of Alendronate versus treatment of Romosozumab. And you see clinical fractures reduced 27%, non-vertebral almost 20%, and what is the most important, that the proximal femur fracture was reduced in Romosozumab, in contrary to Alendronate, 38% fracture. This is really outstanding. If we compare effect of Alendronate on the spinal fracture, BMD, and in green we have Alendronate increase after 1 year, after 2 years, after 3 years. Then we have Denosumab, and then we have Romosozumab. So after 3 years, you have twice higher BMD of spine and much more higher in the total hip. Again, the green is Alendronate increased, the blue is Denosumab, and red is Romosozumab. So increase of BMD after 1, 2, and 3 years each is much more higher in Romosozumab treatment group is as compared to the Denosumab or to Alendronate. What was the problem? That in the ARCH study, there was increase of the cardiovascular incidence. It was just, I think, 5 cases somehow, but it was a big concern. And whether this is the effect of prevention Alendronate or Romosozumab is under discussion. However, the newest publication proved that this difference doesn't exist any longer. But due to that, they get trouble with registration FDA, and you have to obey the remarks that serious problem is some medication must not be given in the patient who have already a heart attack or a stroke, and also not the hypocalcemia, but it is very rare. So if you have patient of the history of the heart attack, you cannot do, you must not do patient Romosozumab because you could be in trouble. However, as I told, no further proof that this is really exist. Here is the meta-analysis of cardiovascular risk of 25 RCTs, 41,000 patients, and you see as a compare there is Alendronate, Raloxifene, Teriparatide is known, and cardiac mortality is known. So key points that Romosozumab did not significantly increase the risk of cardiovascular events, mortality or events, and daily calcium might have no effect with vitamin D, of course. So the Romosozumab might be a safe anti-osteoporotic therapy for post-menopause women. That's the quote of this meta-analysis. So bone forming agents are not the same. I wish to compare Teriparatide, Abaloparatide, Romosozumab, and here we have the gain of the BMD in spine. Here is the Teriparatide, Abaloparatide, and the highest in Romo, and the same in femoral neck, Teriparatide, Abalo, Romo. So Romo is the winner in that competition, but it will be someone better in some time. And the same relates to the fracture risk after the fracture. So those people who are in the highest risk, and you see Alendronate, the incident reduction, and Denosumab, Teriparatide, and Romosozumab has the highest affinity. So we came to summing up. This is not true that only bone remodeling takes place in osteoporosis and have to be initiated with the bone resorption. We have also modeling, which is much more efficient method of bone keeping bone quality. PTH derivates, Teriparatide, Abaloparatide are administered via daily subcutaneous injection, and after 1 year, the therapy should be continued with antiresorptive. However, in Teriparatide, we have no bone loss after cessation. Teriparatide and Abaloparatide lead to faster increase of BMD, and they also bring quicker anti-fracture efficacy. Romosozumab is the antibody to anti-sclerostin, have both bone-forming action and stopping bone resorption, slowing bone resorption. And after 1 year of treatment, antiresorptive therapy should be administered. Head-to-head studies show that Romosozumab is more effective in preventing fracture, even in Alendronate, as we compare the incidence of proximal femur fracture, there was decrease of 38% in Romosozumab group as compared to Alendronate group. Romosozumab is more effective both as compared to Alendronate and Denosumab. And so the cardiovascular is concerned, so in frame study on Romosozumab, there was no differences. Some differences turn out in our study, so it is under discussion, but recent analysis prove that there is no risk. However, FDA have the warning that you shouldn't prescribe the Romosozumab in the patient after the heart attack or other cardiovascular event. This is the meta-analysis I showed you. And really, all of us knows that the optimal treatment for osteoporosis will be started with bone-forming action and then follow up the resorptive to maintain the results. And nowadays, bone-forming medication are preferred therapy in patients with a very high risk of fracture. And with this, I'd like to close this lecture. Thank you very much for your attention. I would appreciate your remarks, questions. You can write just on my web, the contact at osteoporosa.pl, and I invite you to the next lecture. Thank you very much, and see you again.